A nurse calls you over to examine a patient who was admitted to the CCU with cardiogenic shock, who is currently intubated and on mechanical circulatory support with an Impella. The patient has gone into a wide complex tachycardia and is now hypotensive with a narrow pulse pressure. The nurse is unable to palpate a pulse and asks if we should start chest compressions. 4 important questions to consider before starting CPR are: how much cardiac output does the patient require? Is the Impella matching that cardiac output? Is the Impella in the right position? And should you make any changes to pump settings? First, let's consider how much cardiac output the patient needs. Remembering that cardiac index is equal to cardiac output divided by body surface area, we can see that the cardiac output equals cardiac index multiplied by body surface area. Thus, for a small patient with a BSA of 1.4, to maintain a reasonable cardiac index of 2.2, their cardiac output would have to be 3.0. On the other hand, a larger patient with, for example, a BSA of 2.7 would require double the cardiac output to maintain the same cardiac index. In this hypothetical scenario, if the Impella was in a small patient with a BSA of, say, 1.4, they would need 3 liters of cardiac output to maintain a cardiac index of 2.2. Looking at the Impella monitor, we see that the cardiac output is 3.3. Thus, it should be providing sufficient cardiac output to perfuse the patient, even if their heart is not pumping at all. Next, we must consider if the Impella is in the correct position to deliver the reported cardiac output. Here we see relatively flat waveforms in the green motor current tracing and the red placement signal tracing. The red placement signal tracing reflects true arterial pressure detected by a fiber optic sensor in the Impella catheter. The green motor current tracing reflects the amount of energy and flow through the cannula. When the Impella is properly placed, the motor current will be pulsatile, with peaks when the aortic valve is open and there is more energy and flow, and valleys when the aortic valve is closed and there's less energy and flow. When the Impella drifts out of position, the motor current will be flat, because the aortic valve is no longer creating a pressure gradient across the cannula. A flat motor current, coupled with a ventricularized waveform pattern, indicates the Impella has slipped too deep into the ventricle, whereas a flat motor current, coupled with an aortic waveform pattern, indicates the Impella has slipped too far into the aorta. Although a flat motor current waveform should at least make you consider if the Impella is improperly positioned, there is one important situation where a flat waveform can indicate appropriate pump position and function. And that's the waveform we see at the upper left, where the aortic placement signal and motor signal currents are relatively flat. This situation can indicate a well-functioning Impella and a very weak heart. If the heart is barely pumping, you may not see much pulsatility on the aortic waveform, and consequently, there may not be observable pulsatility on the motor current waveform. This is actually an optimal condition for Impella efficiency, which leverages the increased preload in the left ventricle and reduced afterload in the aorta to deliver blood more efficiently through the cannula. We've now seen that for this smaller patient, 3 liters of cardiac output is needed to maintain a physiologic cardiac index, and that the Impella in this scenario is matching that level of support. We also saw that the Impella is in the right position and operating efficiently as indicated by the relatively flat aortic placement and motor current waveforms. Finally, we must ask ourselves if CPR is indicated in this setting. For guidance in this situation, we can turn to the 2022 Handbook for Mechanical Circulatory Support published by the European Society of Cardiology, which has a chapter on Impella troubleshooting and resuscitation. They remind us that CPR should be performed based on loss of perfusion rather than on ECG findings or flattening of the arterial waveform, since the device can often maintain adequate perfusion pressures despite ventricular tachycardia. So in the small patient we just reviewed, jumping straight to CPR would not necessarily be indicated. Let's now imagine, however, that we're dealing with a much larger patient who would need 6 liters of cardiac output to maintain a cardiac index of 2.2. If the Impella is only providing 3.3 liters of additional cardiac output, should you start CPR now? We know that the ESC handbook recommends looking for signs of reduced perfusion, so how can we tell if our patient is being adequately perfused? In 2017, the American Heart Association published an algorithm to help guide when to start CPR in patients with mechanical circulatory support. Although it is focused more on patients with left ventricular assist devices, it seems it should be applicable to patients with Impellas as well. Here they consider a MAP of less than 50 or an end tidal CO2 less than 20 if the patient's intubated, reasonable indicators of poor perfusion that should prompt you to consider initiating CPR, even for patients with well-functioning mechanical support. Finally, the ESC handbook also recommends that if you do initiate CPR on a patient with an Impella, to reduce the P level to P2 to minimize damage to cardiac structures, and to check Impella position with an echocardiogram after ROSC to ensure the Impella was not dislodged during CPR.